Alteration in neural function, concepts of neurodysfunction. This lecture will be done in 4 parts also. Arousal is your state of awareness. It is mediated by the reticular activating center. So your content of thought, the ability to think, is a cerebral function plus that of your reticular activating system. And this was a comic I thought was cute, where Dennis is playing doctor and he says, "I don't hear anything, Joey. Are you sure you're thinking?" Sometimes I know you feel like you can feel the wheels going around in your brain, but it really doesn't make any noise. So if you have a problem with arousal, this is oftentimes due to a structural, metabolic, or psychologic factor that causes damage to your reticular activating system or to the brainstem. You may have confusion, which is an inability to think clearly. This is the easiest thing, the earliest thing, not the easiest, the earliest thing. And I'm sure you've been confused at some time or another, probably after listening to some of my lectures. Hopefully, if that occurs, you will have called me by this time. But anyway, disorientation would be to person, place, and time. Keep in mind, it may not be in that order. People don't necessarily lose their time ability first, or their ability to think of where they are. Taking care of people who have lacunar infarcts, who are just unable to remember who they are, but they know when it is and where they are. So it makes a difference. Don't use those initials unless you identify what they are. Lethargy means they arouse easily, but they're very, very sleepy. Obtunded is they'll have a decrease in verbal response, not quite as aware. It's another step down from lethargy. Then you get to stupor, where you need to vigorously arouse them. You really need to shake them or do some nail bed pressure to get them to wake up. And then with coma, they are unable to arouse. As the nurse, you have got to evaluate their level of consciousness, because a change in intracranial pressure, the first symptom will be a change in the level of consciousness. If you remember back, the first symptom of decreased cardiac output is a change in the level of consciousness. The first symptom of hypoxia is a change in the level of consciousness. And now we have neural problems where you have an increase in intracranial pressure. The first symptom is a change in the level of consciousness. So you need to closely evaluate that level of consciousness. Remember, it doesn't necessarily mean coma. You need to know their pattern of breathing, and there's a table on page 324, and we have talked about that. You need to look at their pupils and see what their size and how well they react are, because pupils will change with drugs. Opiates will cause them to constrict to pinpoint. Hypoxia, they'll become wide and fixed. Atropine, scopolamine, amphetamines, mydriatics all cause the pupils to be dilated and fixed. There's a figure on page 335 you need to look at. You need to know eye position and their reflexive responses. Like, well, do they blink when you put your hand up close to the eye? I mean, even though I'm taping this now, I take my hand to my eye to demonstrate, and I blink, even though I know I will stop my own hand before it hits my nose even. You need to know their skeletal muscle and motor response, whether it's purposeful, inappropriate, or absent. When you're talking about your level of consciousness, are they alert to verbal stimuli or to painful stimuli, or are they totally unresponsive? You need to know this. This is from the memory book. And this is a cute little cartoon. They tell me my short-term memory will increase by 63%. They've given him another brain. I don't think it works that way, but it's an idea. But here we've got short and long-term memory, the mystery of middle age, where you can remember my old high school girlfriend's phone number, but when you go into another room to pick up something, you've forgotten what it's for. This is kind of normal, but it is something to assess for. You need to know their outcomes. Now, cerebral death means they're in irreversible coma. They're not physiologically dead, but their brain is not functioning appropriately. Irreversible coma, will not wake up. Brain death is when they cannot maintain homeostasis. They don't breathe, and they have a flat EEG. You take them off the ventilator, and they die, usually within a few hours. A persistent vegetative state is where they're unaware of themselves or their surroundings, and we'll talk about that a little bit more later on. A locked-in syndrome is where they can communicate only with eye movements, and this does occur with patients who have strokes. A seizure is a sudden, explosive, disorderly discharge of your cerebral neurons. It is characterized by changes in brain function and the level of arousal. A seizure requires 60% more oxygen during the seizure, so they will rapidly go into anaerobic metabolism. And if they have repeated seizures, they will develop irreversible damage due to the lactate production. A convulsion is a combination of tonic-clonic contractions. Epilepsy is the overall term for a condition that causes seizures. So epilepsy is a type of seizure disorder. It can be precipitated by low blood sugar, fatigue, stress, fever, constipation, stimulants, blinking lights, loud noises, odors, and hyperventilation. Seizures can be motor, sensory, autonomic, or psychic in nature. Some seizure terms. An aura is something that may precede a seizure, like within half an hour to an hour. It can be an odor, a vision, a sensation that occurs just before the seizure. Because we have areas of our brain that are more sensitive to changes in oxygen, temperature, low sodium, or sleep phases that cause them to repeatedly fire until a threshold is reached and the seizure occurs. This ceases when the neurons are exhausted. So a prodroma is a sensation that occurs 24 hours before a seizure that says, I'm going to have a seizure tomorrow. The postictal state is the period immediately following a seizure. The tonic phase is when you have increased muscle tone with contraction and loss of consciousness. The clonic phase is the continued contraction and then relaxation of the muscle. Automatism is an automatic action without conscious action or knowledge. So it's something you're doing not really aware that you're doing it. Seizures are now classified by partial seizure or generalized seizure. They used to be different. For example, a partial seizure means that you have no loss of consciousness. A simple partial seizure is one in which only part of the body is involved. It used to be called Jacksonian, so it only affects one arm or one leg or one half of the body, but the patient is awake. A complex partial seizure is when you have a temporal lobe or psychomotor seizure, so it may affect your senses more than actual physical movement. Generalized seizure means there is a loss of consciousness. The most common in children is an absence or petit mal seizure. This is picked up by teachers more often. It's where the child just gets this blank look on their face and maybe 5 minutes later doesn't realize everything else has gone on around them. Oftentimes they'll grow out of this. Atonic or drop attacks, where they just kind of suddenly pass out. Or myoclonic is another type. Tonic-clonic seizure or grand mal seizure is a type of generalized seizure. Status epilepticus is when you have continuous seizure activity. It is a common life-threatening emergency of your tonic-clonic convulsions. You'll have brain damage and death if it is not resolved quickly and if it's not treated. And there's a table on page 340 in Huther that talks about the different seizure classifications. In seizures in children, the usual cause is asphyxia, intracranial hemorrhage, central nervous system infection, injury, electrolyte imbalance, or an inborn error of metabolism. 80% will occur before the age of 20, and there's a table on page 414 that talks about the types with their associated cause. Usually, if somebody has a seizure, they don't treat the first seizure because of what it could be due to, the comorbidities that cause it, but they will treat the second seizure with your anti-epileptic drugs. Cognitive disorders. Agnosia is the failure to recognize the form and nature of objects. A sensory attentiveness is when you only recognize something if it's pointed out to you. Extinction is where you get no reaction if you're stimulated on both sides. And neglect syndrome is denial of dysfunction and loss of recognition of your body parts. Dysmenesia is loss of past memories with the inability to form new ones. Dysphagia is impaired comprehension or production of language or symbols, either written or verbal, where aphasia is the loss of comprehension or production of language or symbols. Receptive aphasia is where the person is talking to someone, or someone's talking to the patient, and they don't understand a word that's being said. Expressive aphasia is when the patient's trying to respond to a question and you don't understand anything that's being said. And global is where they cannot communicate either. Understand what you're saying or say something that you understand. Keep in mind this is affecting the areas, Broca's area in the brain, which is your motor aspect of speech and writing. It's usually on the left. Or Wernicke's area, which is your reception and interpretation of speech. This is located in the occipital parietal area, and it's usually on your dominant side. Echolalia is where you have an involuntary repetition of words, and you'll notice your patients in psych will do this oftentimes. They'll repeat the words that you say to them. Delirium is associated with overactivity. Symptoms are a stress response activated, inattentive to things, they're violent, they may have hallucinations. And a hallucination is a fake perception that's not related to reality. Dementia, on the other hand, is loss of more than one cognitive function. Amnesic dementia is loss of recent memory. Cognitive dementia is loss of remote memory. And intentional dementia is loss of vigilance, which is to be attentive, alert, and watchful. And your executive function, which is your thinking and reasoning ability. And this is looking at dementia and some of the things that could mimic dementia that you need to look at. Again, from the memory book. Degenerative diseases of the brain. We have Alzheimer's disease. And the cause is loss of your neurotransmitter stimulation, an accumulation of amyloid plaques. It could be a gene defect, but they form neurofibrillatory tangles, and you get terminal axons that degenerate. Senile plaques that disrupt nerve impulse transmission occur. And so your patient is forgetful, disoriented, confused, has no math ability, behavior changes, and decreased judgment. And I was sent this poem by email, and it kind of fits with Alzheimer's. But it fits for other people too, but here's the poem. My forgetter. My forgetter's getting better, but my rememberer is broke. To you that may seem funny, but to me that is no joke. For when I'm here, I'm wondering if I really should be there. And when I try to think it through, I haven't got a prayer. Oftentimes I walk into a room and say, what am I here for? I rack my brain, but all in vain. 0 is my score. At times I put something away where it is safe. But gee, the person it's safest from is generally me. When shopping I may see someone, say hi and have a chat. Then when the person walks away I ask myself, who was that? Yes, my forgetter's getting better while my rememberer is broke. That's driving me plumb crazy. And that isn't any joke. Alzheimer's disease is fatal. Patients do tend to die of aspiration pneumonia. It is a very sad disorder because the family is the one who has to cope. It's really eventually harder on them than it is on anybody else. Increased intracranial pressure occurs with head injury, among other things, tumor, trauma, or edema. Our normal intracranial pressure is around 5 to 15 millimeters of mercury, so it's not very high up there. There are different stages. Stage 1, you have no signs and symptoms because all that's being displaced is your cerebrospinal fluid. Stage 2, you have a change in your level of consciousness. Again, This may not mean coma. It usually means restlessness, anxiety, a feeling that something's not right. Stage 3 is when you start to get a change in your pupils. You'll have a decrease in your level of consciousness, a widened pulse pressure, bradycardia. Your pupils will be small with a sluggish reaction, and you may or may not be hyperventilating. Stage 4 is the stage you want to definitely prevent forever, because this is when your brain tissue actually herniates to an area of lower pressure, usually down the brainstem. And this will decrease the blood supply to the brain in that area, causing necrosis, a new area of hemorrhage, a new area of inflammation, and everything just tends to get worse. When your mean arterial pressure equals your intracranial pressure, there's no blood flow to the brain at all. There's a figure on page 349 that discusses this. And this is showing you some of the symptoms of increased intracranial pressure. And again, you have vital signs with increased intracranial pressure. To have elevated systolic blood pressure with bradycardia and a wide pulse pressure, that's Cushing's triad, and that is a very, very, very bad symptom. Patients rarely survive that. Cerebral edema is an increase in fluid content of the brain tissue, resulting in distorted blood vessels, displaced brain tissue, and herniation. There are 4 different types. Vasogenic is due to an increased permeability of your capillary endothelium after injury to the vascular structure. Your plasma proteins will leak into the extracellular spaces. This tends to be mainly of the white matter. Cytotoxic or metabolic is due to toxic factors that alter the cellular elements, so the active transport fails, causing sodium to enter the cells and potassium to leave the cells, causing the cells to swell. This is mainly the gray matter. Ischemic is due to a cerebral infarct, and it affects both the white and the gray matter. And you can also have interstitial, which is due to a non-communicating hydrocephalus that expands the area and puts pressure on the surrounding area. And here's hydrocephalus, where you have excessive fluid in the cranial vault and or the subarachnoid space due to a problem with cerebral spinal flow. Either an obstruction, an increase in production, a defect with reabsorption, or whatever, it causes an increase in intracranial pressure. This is showing what happens in a child. On the left is the normal, on the right is hydrocephalus. This is an infant because you can see the fontanelles, or the suture line at the top is able to expand. Alteration in muscle tone is hypotonia, where you're going to have a decrease in muscle tone. Symptoms are asthenia, where they tire very easily, weakness, and the need to assist them with their movements. Hypertonia is when you have an increase in muscle tone. You'll have spastic movements, such as hyperexcitability of your stretch reflexes that are associated with hyperflexia and clonus, which is the spread of reflexes. Gegenhalten or paratonia mean exactly the same thing. Gegenhalten is resistance to passive movement, and this is associated with a frontal lobe injury. Dystonia is where you have slow muscle contraction that results in sustained twisting movements. Rigidity is where you have firm, tense muscles. Please remember, you need dopamine for muscle movement. When it's decreased, you have akinesia. When it's increased, you have chorea. Alterations in movement, you have paresis, which is weakness, and paralysis, which is the inability to overcome gravity. You could have hemiparesis or paralysis of half of the body, or you can have paraparesis or paraplegia, which affects the lower extremities. Quadriparesis or quadriplegia affects all 4 extremities. Paresis, weakness; paralysis, unable to move, or unable to overcome gravity at all. Hyperkinesia is excessive movements. You'll have paroxysmal dyskinesia, which is abnormal, involuntary movement similar to spasms. Or tardive dyskinesia, which occurs most often due to drug therapy, such as with phenothiazines. You'll have involuntary movement of your face, the trunk, the extremities. You'll have rapid, repetitive, stereotypical movements, like chewing with protrusion of the tongue while you're chewing. Not something necessarily is pleasant to see. And this is showing the different types of paralysis: quadriplegia, paraplegia, and hemiplegia. And that finishes part 1.